Welcome back, everyone. Today we are diving into the absolute marvel of human engineering, the synovial joint. Dr. Khan, I am fired up because these aren't just hinges on a door. They are high-performance, self-lubricating, pressurized systems that allow us to do everything from sprinting a marathon to performing neurosurgery.
It is great to be here, Dr. Khan. While you see the performance, I see the precision that the boards love to test. For students listening, synovial joints are the most common and complex joints in the body. To master them, you have to understand the interplay between the fibrous capsule, the synovial membrane, and that critical lubricating fluid. It is a specific triad of structure that defines this category.
Right, and let's start with the container, the fibrous capsule. I like to think of this as the heavy-duty canvas of a tent. It is tough, it is fibrous, and it holds everything together. But why does this matter clinically? Well, if that capsule is too tight, you lose range of motion. If it is too loose or torn, you're looking at a dislocation. Sarah, what is the high-yield fact about how this capsule relates to the synovial membrane?
This is a classic exam favorite. The fibrous capsule is the outer layer, but the synovial membrane lines the internal surface of that capsule. However, and this is a major point, the synovial membrane does not cover the articular cartilage. It stops right at the margins of the hyaline cartilage. If an examiner asks what covers the weight-bearing surface, the answer is hyaline cartilage, never the membrane.
That makes perfect sense. If that delicate membrane was on the weight-bearing surface, it would be crushed like a grape every time you took a step. Instead, that membrane is like a high-tech factory. Its sole job is to secrete synovial fluid. Think of synovial fluid as the ultimate WD-40, but better. It reduces friction to almost zero. Without it, your bones would literally grind themselves into dust.
Exactly. And that fluid isn't just for sliding, it is also for dining. Remember, articular cartilage is avascular. It has no blood supply of its own. It breathes and eats via the synovial fluid. This is why movement is medicine. When you move a joint, you are essentially pumping nutrients into the cartilage and flushing waste out. If a patient is immobilized for too long, the cartilage actually starts to starve.
That is such a key point for the clinic. Motion is lotion. Now, let's talk about stability. A synovial joint is freely movable, which sounds like a recipe for disaster. Why don't our shoulders just fall off when we reach for coffee? It comes down to the three big factors: the shape of the bones, the ligaments, and the real MVP, muscle tone.
Muscle tone is definitely the highest yield for clinical practice. Take the shoulder joint, for instance. The glenoid cavity is incredibly shallow. It's like a marble sitting on a saucer. The bones provide almost zero stability. It's the rotator cuff muscles, through their constant tonic activity, that keep the head of the humerus pulled into that socket. On an exam, if they ask what the primary stabilizer of the shoulder is, don't just say ligaments, it's the muscles.
And when those muscles fail or fatigue, the ligaments have to take the brunt of the force. But ligaments are like old rubber bands. If you stretch them for too long, they stay stretched. Why does this matter clinically? Think of flat feet. If the muscles of the leg that support the arches get tired, the ligaments stretch, the arch collapses, and suddenly you have a patient in chronic pain. You want to be the doctor of choice for these patients by catching that muscular weakness before the structural damage is permanent.
Speaking of clinical presentations, we have to mention Hilton's Law. This is a favorite for neuromusculoskeletal questions. Hilton's Law states that the nerve supplying a joint also supplies the muscles that move that joint and the skin covering those muscles. This is why a patient with a hip issue might complain of knee pain. The obturator nerve is pulling double duty, and the brain gets the signals crossed.
The referred pain trap. I see that all the time in the ER. Now, Sarah, the book mentions bursae and synovial sheaths. I always tell my students to think of a bursa as a tiny fluid-filled pillow. They're tucked into high friction spots, like where a tendon rubs over a bone. But what happens when things go wrong?
That leads us to bursitis. Think of housemaid's knee, inflammation of the prepatellar bursa from too much kneeling, or tenosynovitis, where the synovial sheath around a tendon gets inflamed. From an academic standpoint, you need to know that these sheaths are just tubular bursae. They have a mesotendon that allows blood vessels to reach the tendon without being pinched during movement. If that sheath scars down, the tendon can't slide, and you get trigger finger or major loss of function.
It's all about that smooth glide. If we lose that mechanics, we lose our independence. Clinically, we also see this in arthritis. You have your inflammatory types like gonococcal arthritis affecting the large joints, or the degenerative types where the hyaline cartilage simply wears out. When that blue-white hyaline cartilage disappears, you're left with bone-on-bone contact, which is excruciating because bone is highly innervated, unlike the cartilage itself.
To wrap up the mechanics, let's summarize the must-knows for the boards. 1. Synovial joints are defined by a fluid-filled cavity. 2. The synovial membrane produces the fluid but does not cover the articular surfaces. 3. Hilton's Law explains why joint pain can be so tricky to localize. And 4. Muscle tone is usually more important for stability than the ligaments themselves.
Beautifully put. Clinically, just remember, a joint is only as good as the fluid inside it and the muscles around it. Keep your patients moving, protect their pillows, the bursae, and always check the joint above and below where the pain is. That is the secret to mastering joint mechanics.